Welcome to the ECNP Congress Preview podcast series, where speakers from the upcoming ECNP Congress in Amsterdam share their perspectives on the current state of their field, highlight key challenges and emerging opportunities, and offer a preview of what to expect from their symposium session at the Congress.
Hello. In this Congress Preview podcast, we will talk about our symposium entitled A Long Way to Go, Insights from Longitudinal Studies in Bipolar Disorders, which we will present at the 2025 ECNP Congress in Amsterdam on October 14th. My name is Luisa Klahn, and I am a researcher at the University of Gothenburg, where I investigate the neurobiology of cognitive and functional impairments in bipolar disorder. Today, my fellow speakers and I will discuss current challenges in the field and the latest insights from longitudinal studies. Danella Hafeman is an associate professor of psychiatry at the University of Pittsburgh. Her research is focused on youth with and at risk of bipolar disorder. Hanne Lie Kjærstad is a researcher at the Psychiatric Center Copenhagen with a research focus on cognitive and neuroimaging biomarkers in newly diagnosed patients with bipolar disorder and their relatives. And Tomas Hajek is a professor of psychiatry at Dalhousie University in Halifax. He will present his research on body mass index as a predictor of brain change in bipolar disorder. Tomas, why are the findings you will present important to our field?
Well, whether it's important to the field, I'll have to leave that to others to decide. I can tell you why it's important to me. And it is important to me because it addresses one of the most puzzling things that I find in my clinical practice. And the thing that I find so puzzling is that in my practice, I have clients who can get very sick during the episodes, but then they recover both in terms of their symptoms as well as their functioning, and they return to work. I have other people who may recover from the episode in terms of their symptoms, but they never regain their full functioning and they are unable to return to work. So the question as to why people with the same diagnosis have such vastly different outcomes has been bugging me for a while now. And this clinical heterogeneity is obvious to any clinician. What's probably less obvious to people is that we see similar differences in neurobiological findings across people with the same diagnosis of bipolar disorders. So specific to my talk, there are people with bipolar disorders who have very pronounced brain alterations, but there are other people with the same diagnosis whose brain essentially looks intact, and we cannot differentiate it from brains of control participants who don't have bipolar disorders. So effectively, my research focuses on why people with bipolar disorders differ so much in their brain alterations and whether these differences translate into also differences in clinical outcomes. So effectively, I'm looking at risk factors for brain changes and associated poor clinical outcomes. And the risk factor that I find most interesting in this context is obesity. And as we know, obesity is extremely frequent in people with severe mental illnesses, with maybe 3 times greater odds of obesity relative to general population. We also know that obesity impacts the brain, and I'm not talking about the sort of macrovascular complications of stroke. Obesity actually is associated with subcortical atrophy, cortical thinning, even when you control for any of the cardiovascular risk factors. So my thesis is that obesity could be the extra dimension that modifies the clinical course and clinical manifestations, the psychiatric ones, in people with bipolar disorders, and does this through the effect on the brain.
Thank you very much, Thomas. I think this is a very important perspective because you're highlighting factors that might easily be overlooked. Thank you. Let's move on to Danella. You are studying the long-term course of bipolar disorder in youth. What have been some of the most important insights, and how might these findings inform early intervention?
Yeah, so for ECNP, I'm going to be talking about findings from two different studies. One is the Course and Outcome of Bipolar Youth, or COBE study, which has followed youth for more than 10 years, many of them diagnosed quite young, and looking at their course into early adulthood. And then the other study is more recent and only 2 years of follow-up, but using more sort of mobile sensing and kind of dense sampling to try to understand course. And really, this work is driven by wanting to kind of predict the outcomes for people. As Tomas mentioned, there's a lot of heterogeneity across outcomes. So can we kind of understand early on who is going to be at most risk for these outcomes? And especially if we can understand when they're going to happen, then we can intervene early. So to get into a little bit more of the details, I think one of the insights from the long-term COBE study is that there is actually quite a bit of continuity of diagnosis between childhood and adolescence and at least young adulthood. It's not 100%. So there are some people who don't continue to have manic symptoms into adulthood, but most do, particularly those who continue in adolescence, which I think is really important because there's been sort of this question of whether, the younger people who are getting diagnosed are similar to those who are older. So showing that continuity is important. But at the same time, it's not monolithic, right? So there's a lot of heterogeneity. And while some people continue to have symptoms, some people get a lot better. So a while back, we did a latent trajectory analysis, which I'll be talking about in the talk. Really, that showed that there were two classes of individuals, improving and well, that actually didn't continue to have these symptoms. So with that heterogeneity, it really brings it to what do you tell a patient and their family, when they're getting a diagnosis of bipolar disorder, when we're starting on medications. And this is where something called a risk calculator comes in. So that's another kind of insight from these studies is, can we use what we know about the course and prediction of mood episodes to then say, for the person sitting across the room from us in a clinical encounter, what is your particular risk of having a mood recurrence? And so part of what I'll be presenting in the talk are our risk calculator models that do that and have been now externally validated as well. And then the final part is really that how can we use other measures other than just clinical measures to predict risk. And so here we have the mobile sensing from our recent study. And this takes, something that everybody has, especially young people, a smartphone, and that, often at their fingertips, right? Even overnight. And looking at measures collected from the smartphone, reflecting things that we know are important for bipolar disorder recurrence, including sleep, mobility, social interaction, and whether we can use that to then predict who will have an imminent mood episode recurrence. And so far we have some pretty interesting data that I'll present at ECNP related to sort of physical activity and sedentary being related to depression and mania in opposite directions, a proxy for sleep, and then also smartphone interactions like screen unlocks being associated with mood episodes. So I think this is promising because it's something that almost everybody has, and that, through sort of passively collected data, if we could get this kind of early warning sign, would we be able to intervene in a more timely manner and hopefully improve the course of the illness for individuals. So I'm excited to give the whole talk at ECNP.
Thank you so much. Super interesting. And I also think this is a very important perspective because we all know that many changes, being brain changes or also cognitive changes, happen at early stages of bipolar disorder, so around the onset of illness. So I think it's super important to focus on risk factors and early intervention strategies. Yes. And speaking of early, Hanne, you investigated newly diagnosed patients. do your findings point out early markers that might predict the cause or the severity of illness?
Yeah, so our findings do actually point to some early markers that may help us predict both the cause and severity of bipolar disorder. So in our study, which is called the BIO study, the Bipolar Illness Onset Study, we're looking at a large cohort of patients who are early in their diagnosis. So they were newly diagnosed from the clinic. And my work focuses specifically on the cognitive and neuroimaging components of this cohort. So we now know that patients with bipolar disorder, cognitive impairments are a core feature of the disorder. And that's because they persist throughout periods of remission. So they go beyond these acute mood episodes, and they also contribute to reduced psychosocial functioning. But that said, like the other speakers also mentioned, there's a lot of heterogeneity in cognition in patients with bipolar disorder. So not all patients are affected, and they are not affected in the same way. So we have used some data-driven analysis where we've identified a subgroup of patients with broad cognitive impairments, and this is both within non-emotional domains, such as what we typically think of as cognition, so executive functioning, attention, processing speed, and so on, but also within emotional cognitive domains, so where they have difficulties with facial expression recognition, emotion processing, and regulating their emotions. So this subgroup of patients, they seem to be particularly vulnerable, where we see that cognitive impairments are evident already at the time of diagnosis, and they are prospectively associated with a more severe course of illness. So we see that these impairments are then associated with a higher risk of relapse. They have more frequent psychiatric hospitalizations, and they also show a lack of improvement in functioning over time. And these cognitive impairments, they are also associated with more persistent prefrontal hyperactivity, so particularly in the dorsal prefrontal cortex during tasks that engage cognitive control processes such as both working memory and emotion regulation paradigms. So this dorsal prefrontal cortex activity, particularly during emotion regulation, actually, is associated with a greater likelihood that patients have experienced more mood episodes. And this then we interpret as being a viable marker of illness progression. So our findings then support the value of neurocognitive and neuroimaging assessments. And we think that, especially those that focus on emotion regulation and prefrontal dysregulation, they may be used to identify individuals at a higher risk of a poorer outcome. So this knowledge basically could then be used to guide early targeted interventions that are aimed at improving cognition and effective functioning to mitigate the risk of adverse illness trajectories.
Thank you so much, Hanne. Very interesting, and I see how your research has very important implications. And I also wanted to add what a huge effort went into all of the findings you talked about. We all know that longitudinal studies are both time-consuming and resource-intensive, which partly explains why they remain relatively rare in our field. Yet such studies are essential for understanding the long-term course, prognostic markers, and treatment outcomes of this complex condition. Still, every study is designed differently. I, for example, work with the St. Joran project, where patients are followed up over 14 years, collecting clinical, cognitive, and brain imaging data, as well as fluid biomarkers, with a focus on identifying predictors of long-term outcomes. And you have already described a little bit about the studies you're working with, but I thought we can highlight this a little bit more now. So let's talk about the core features of the studies you will present. Danella, would you like to start? What is the main characteristic of your study?
Sure. Well, I think, right, with longitudinal studies, they can be very challenging, and the devil is always in the details, in the methods, right? And so I think some of the things that really characterize our work, and I'm sure your all's work too, but first a very careful diagnostic assessment. And I think this is especially true when you're looking at young people, and sometimes you can't make the diagnosis right away, right? So some of our people in the COBE study, they were in there sort of provisionally for a while as you sort of like better understand their course. And is this bipolar disorder, or is it better explained by behavioral disorder like ODD or ADHD, right? So there's that sort of very careful diagnostic assessment that, for our studies often takes 3 to 4 hours, and it is just very resource intensive. Now, in terms of the longitudinal follow-up, I think it's also the measures used are critical. So really key to a lot of our COBE analyses were weekly retrospective assessments of mood and various other things, comorbidities like anxiety and substance use. And that sort of temporal fine tuning of when things are happening and what the sort of episodicity is of things is also critical to these questions. So, we were seeing people every 6 months, but getting then the retrospective to the best of our ability, weekly assessments of, when was mood more depressed and these sorts of things. And then the last piece is integrating the mobile sensing. And I think there it's an understanding that we're in the early phases and that to be able to really bring this sort of to clinical fruition, we're really going to have to think a lot more about how we're collecting this data and the systems for then giving the feedback, the clinical feedback that we need in real time. So those are what I would say are our main sort of methodological kind of pillars, and also, future directions.
Great. Thank you so much for that thorough explanation. Hanne, what would you say? What is specific about the longitudinal study you are working with?
Yeah, so I'm working on the bio study, and it's a large-scale, an ongoing research project that we started back in 2015, and it's led by Professor Lars Kissing. And we've followed a large cohort of over 700 individuals. And as I mentioned, we have a lot of patients who are newly diagnosed with bipolar disorder, which is pretty unique to our sample. And we have around 140 of their unaffected first-degree relatives who have no psychiatric history that we are also following up over time, and healthy control individuals. So this design of the bio study then allows us to investigate both like the high-risk states and early illness trajectories, including this transition from risk to onset. And we can also then investigate the recurrent mood episode relapses over time and how they can have a potential neuroprogressive effect over time. So right now we're actually collecting the 7 to 10 year follow-up data. And in addition to these comprehensive cognitive assessments that I talked about previously, we are also gathering quite a broad range of biological data. So we have blood, hair, and urine biomarkers, as well as fecal biomarkers. And then we are looking at digital phenotyping through smartphone-based monitoring as well. So the whole goal of the bio study eventually is to integrate all of this wealth of data to identify a composite multi-level biomarker that can both help us predict illness onset in those who were unaffected at baseline, and to predict mood episode relapses in those who were already diagnosed.
Hanne, I think you mentioned a very important point, because in psychiatry, we are not, and perhaps we will never be at that point where we can just take one single marker to determine an illness. So these multimodal approaches are really important to our field. And Tomas, what would you say? What are the characteristics of your data sets?
Yeah. So in general, I think the unique thing about the study is, first of all, the focus on trying to identify risk factors for future brain and cognitive changes. And if we can do that, then we would have a way to actually prevent, or if these are modifiable risk factors, to even treat that risk factor and then see whether that will have a positive impact on the brain. And the word prevention and psychiatry doesn't usually go well hand in hand. So I think this is quite novel. Also, the switch of focus from treating symptoms, which we know is not going to get us to full functional recovery, to focusing on how we actually heal the brain, the very substrate of these disorders, is an important shift that we should look for as a field. Now, for any of these objectives, you really cannot do this with a cross-sectional study. You need a longitudinal study design. And I think people still underappreciate the benefits of the longitudinal studies, and they overappreciate the cross-sectional studies. I think we've pretty much learned as much as we can from cross-sectional research. And I'll give you an example why we need to step it up now. So in our previous studies, we have shown that there is an association between obesity, you can measure that by body mass index or waist to hip ratio, and brain changes. But this doesn't tell you, everybody knows that association is not causation. And in a cross-sectional study, an association doesn't tell you what came first, right? It can be that certain configurations of the brain may make you more likely to gain weight, such as through impulsivity or impaired homeostatic signaling or impaired reward signaling. So you are in a position where you are more likely to gain weight. It's also possible it's the other way around, where obesity may impact the brain, and there's many mechanisms through which that could happen. Could be inflammation, could be dyslipidemia, could be hyperglycemia, could be microangiopathy, vascular risk factors. So it could be that the obesity is the thing that's damaging the brain. Now, in a longitudinal study, we cannot get to causation, but we can at least see what came first, whether obesity predicted future brain changes or baseline brain state predicted future increase in weight. And so that's what I'll be talking about. If you want to know what we discovered, you need to come to the symposium. I'm not going to give you any spoilers. I'll end it on a cliffhanger rather.
Great. Very good. Yes, and I think when we wrap that up now, together we can cover almost the whole of the lifespan. And Tomas, you summarized it really well that we have already learned a lot, but as the title of the symposium says, we still have a long way to go. I would like to thank all of you. It was a pleasure to talk to you today. And I think I can speak for all of us that we are very much looking forward to our symposium, and we hope to see as many of our listeners at the ECNP Congress in Amsterdam. Thank you very much.
Thank you.
Thank you. See you at the symposium.
Thanks for listening to this podcast from ECNP. The views and opinions expressed in this podcast are those of the interviewee and do not necessarily reflect the official position of ECNP. The content of this podcast should not be used in any way as the basis for treatment decisions.